So again, this simple design, a one group pre-test, post-test design, where you measure a group of people, do something, intervene in some way, and then test them again and measure the difference between these. That simple design has a huge amount of potential problems, which is why this design is not usually used in science. Just to go over these again, maturation means the participants themselves change in between your first and second test, between the pre-test and post-test, in other words. History means that some other event other than the, or set of events other than the intervention influences the difference between the pre-test and post-test. Regression, specifically something that happens when we take a group of people with an extremely high or low average score. Attrition means dropout. What if the people who drop out have an on average low or high scores? That changes the overall mean. Testing means an influence from the pre-test on the post-test. And instrumentation means that our measuring device changes. In psychology, the measuring device is obviously often an observer, right? A human being. So again, the usual way in which we deal with these problems, is to have a control group, right? If what happens in a control group is different than what happens in the treatment group, then we often can rule out these things. However, even when we have a control group, like I said, often we can rule these out, but not always. Even when we have a control group, there may be problems. Example, when we use a control group, something that may happen is a selection history threat. Remember, history is an event affecting the scores. Well, what if we have a control group and we have an event that affects one group but not the other, or affects one group more than it does the other, right? So here a selection history threat is defined as an outside event or factor that systematically affects participants at one level of the independent variable, but not, or less so, another level. Let's say that we again have two dorms. We test both dorms, then one dorm gets the Go Green campaign, and then we test them again, and let's say that the dorm that has the Go Green campaign did indeed use less electricity than the dorm that did not get the Go Green campaign. Well, what if there was a power outage in one dorm, or let's say there was a lot of construction going on in the other dorm, thus that increased the electricity use, right? That would be a selection history threat. So again, in that situation too, we can't be sure whether the difference, right, in this case in electricity use, was caused by the intervention, in this case the Go Green campaign, or was it the history effect, right, the construction. So that too is a threat to the internal validity. Likewise, we can have a situation where we have a selection attrition threat. Remember, attrition is dropout. What if we have a situation where one group experiences more attrition than the other group? Imagine we have two depressed groups. One receives therapy, one's a control group, but in the therapy, the most depressed people drop out, thus artificially reducing the average, but not in the control group. That too can be a situation, right? We call that selection attrition. So there too we have a situation where we have a threat to the internal validity. We can't be sure if it's because of the attrition or because of the effect of the treatments. Even so, there are other potential threats to the internal validity, in fact, that might apply to any type of design. One is observer bias, something that we've already talked about, right? Observer bias happens when researchers' expectations influence their interpretation of the results. The therapist who expects their patients to improve may indeed see that improvement because that's what she looks for, not because they actually improve. Likewise, what was it? The camp guy who may expect the boys to reduce their rowdiness may see that because they expect that, not because they are actually reduce their rowdiness, right? That's observer bias. We tend to see what we expect to see in many situations. So observer bias can threaten the internal validity of an experiment. Is the difference that we see, is that because of an actual difference or because of observer bias? Note that observer bias also threatens the construct validity, right? Construct validity means measuring what you think or hope to measure. So do you measure what you're actually measuring, or are you measuring the researcher's expectations? A second potential threat to the internal validity of any study is what are called demand characteristics. Demand characteristics are a problem when participants guess the hypothesis of the study, or guess what the conditions of the study are. Right? Anything about a study or an experiment that tells the participants what the study is about, or tells them how to behave, or suggests some way of behaving, that's called demand characteristics. So when participants guess the purpose of the study, it doesn't have to be the true purpose of the study, but guess the purpose of the study, or a purpose of the study, they may change their behavior. Some people may try and live up to that purpose. Other people may actually try and do the opposite of what they think is expected of them. Either way, we're not measuring what we hope to measure. And we may not measure a difference between scores that reflects a true difference, but it may reflect demand characteristics. So how do we control for observer bias and demand characteristics? One way in which we could do that is to keep both the participants and the observers blind to the different conditions. In other words, the participants don't know whether they're in the control condition or the experimental condition, and the people who evaluate them, the observers, also don't know whether they're in the experimental condition or in the control condition. All right? So that, for instance, is why we want to put some people on a placebo pill and some on the actual pill. The people in the control group receive a placebo pill, the people in the experimental group receive the actual pill, and we don't tell them which one is which, so their expectations don't differ. But then at the end, the people who evaluate them also don't know which person received the placebo and which person received the actual drug, right? That's called a double-blind study. So blind doesn't mean literally blind, it just means that neither the participants nor the people who do the evaluation, the observers, know who was in what condition. Sometimes it's of course impossible, right? In the study where we put students in a take notes on laptop or notes with pen and paper condition, obviously people knew whether they were taking notes on laptop or pen and paper, right? But we can still have a situation where the observers, the people who evaluate them, are blind. This is called a masked study, or sometimes a single blind design, right? Where people know or understand what's being done to them, because it's impossible not to have that. But at least the evaluators, aka observers, don't know who was in which condition. Third potential internal validity threat, again in any study, are placebo effects. Right? So you know what a placebo pill is a pill without active ingredients, we've already mentioned this several times already now, or placebo injection, that same thing. But there's also a placebo effect, which is any treatment, whether it's pill or psychotherapy or whatever, has an effect because the people who receives it believes and expects an effect, right? This is very, very well established. That if we give depressed people a pill and tell them it's an antidepressant, they'll feel better. If we give anxious people a pill and tell them it's an anti-anxiety pill, they'll feel better. If we give people who have a headache, an anti-headache pill, or tell them it's an anti-headache pill, they'll feel better because of a placebo effect. The opposite actually also works. If we give people a pill and tell them that it may cause headaches, they'll get headaches. If we tell them that it may cause rashes, then they'll develop rashes. This is very, very well established in pharmacology. Some would say that the placebo effect is one of the best established findings in pharmacology. So if we put people through a treatment, whether it's psychotherapy or a drug treatment, and they show improvement, how do we know that improvement isn't a placebo effect? So again, right, we can have a double-blind placebo control study where one group receives the true therapy and one group receives a carefully designed placebo therapy. And if we see an improvement in the true therapy group that is greater than whatever we see in the placebo therapy group, then we can conclude that that's due to that this difference would be due to the effect of the actual therapy and this due to the placebo effect or any of the other effects we already talked about. Right? In this situation, both groups improved compared to their pretest measurement, but the true therapy group improved even more, so we know that this difference would be due to the effect of the true therapy compared to the placebo. Like I just mentioned, this improvement may be because of the placebo effect, but it may also be because of any of the other threats to the internal validity that we've mentioned, right? History, maturation, and so on. If we really wanted to know which part was placebo and which part was due to the other ones, we could have two control conditions. One a placebo therapy condition and one no therapy condition, where people just waited or didn't do anything. Now we have three conditions, one experimental condition and two control conditions. And if we compare these, we would know that this part would be due to the true therapy and this difference would be due to the placebo, and perhaps this difference compared to baseline would be due to any of those other factors. So, careful experimental design can tease these effects out, right? In this situation here, we have one true therapy group that improved this much, one placebo therapy group that improved this much, and one no therapy group that improved it this much. So we know that this difference is due to the effects of the true therapy, and this difference is due to the placebo. So we have now discussed a large number of potential threats to the internal validity. That means potential confounding factors in an experiment, and good experimenters understand these and design their experiments to control for these. Right? And if one study can't control for all of these, then we do a bunch of follow-up studies that can one at a time control for all of these, and thus our, knowledge improves. Right? We talked about design confounds, selection effects, order effects, potential effect of maturation, history, regression to the mean, attrition, testing, instrumentation, observer bias, demand characteristics, and the placebo effect. Right? All of these are potential threats to the internal validity. And once again, a well-designed experiment controls for these.